Thanks, Rosa.
Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Please feel free to ask questions as we go along and they'll be addressed. I'm honored to introduce our mentor for today, Dr. Cheema. Dr. Cheema is an accomplished internist. She is an attending physician affiliated with the University of Maryland Medical System and teaches residents and medical students. She completed her internal medicine residency at the University of South Florida. She is a mentor to students and a published author in neuroendocrine tumors and infectious diseases. Dr. Cheema also participates in community services and believes in health for all. She's also running a clinic for low-resource patients. And now it is my honor to request Dr. Cheema to begin today's session. Thank you.
Thank you, Minahil. Very good morning, everyone. I'm thrilled to be with you again this morning. And as I mentioned in my previous session as well, I would like this session to be more interactive and I would like your participation as well. And most of you know from my prior sessions that I would like to start with why. Why are we here? So I would like your participation. I need to know why you guys are here. It's very deep and thoughtful to ask ourselves why we are here on this weekend morning. We can be with our loved ones, with our friends, with our family, but we are here together this morning. So we need to deeply aware about our why. Why are we here? So let's see if we can get some responses in the chat box. If someone want to talk, you can unmute and you can talk about your why. Because every time I start with why, because by asking ourselves why we are here, why it helps us motivated. It will help you guys to be more interactive. It will help you to learn with total physical interaction. So there's a reason I always try to start with why. So this will help us why we are doing what we are doing. All right. So let's see. I'm here because I want to stay inspired on my path to medicine, learning from my physicians along the way. Okay, good. Yeah, so I would like to share that we all have our why. So we just need to define. So we got another response. Good. I really want to learn more about internal medicine because that's one of the areas of medicine I'm most interested in. Okay, great. Awesome. So as I mentioned, we all have our why. So if we define our why, it will be easy for us to keep us motivated and learn with more happily, and it will absorb the information. And when we know our why, how will be easy for us. So always start with why and how will be easy for you. So that's why I want to discuss with you my why I am here with you this morning, why I'm thrilled to be here to be with you this morning. Because I want to have a positive impact on the community, to lift up the society. It's like one candle lit another candle. I was in your shoes at some point and someone was teaching me, right? So it's my turn to pay back to the community. And the reason we are here together, this shows our passion of learning. And passion, I would say this is one step toward achieve your goals, whatever you have set your goals in your life, to improve your learning curve. And when we are passionate about it, we're out of time and space. And when it's truly cherishing to play a vital role in patient care side and influence medicine in other ways as well, being impactful in general, talking about and discussing the cases together and engaging with the community, with the students and with the residents. And I would say it's really beneficial circle of teaching the future healthcare professional and taking care of the patients. And I would also like to add on, one-to-one interaction is so influential and impactful in serving the humanity. And I feel we all are blessed. We all woke up this morning and here together to learn. And so this time that we spend together, I would like to be fully engaged, fully interactive with the session, so you can learn more actively and do with total physical interaction to refresh your knowledge and improve your learning curve. All right, so I would like to start now. We are going to talk about the abdominal regions, and I will start with very basics, and then we'll go on the cases and talk about it. So I'm going to go with the abdominal regions first. So we have 9 abdominal regions, so we'll have a better idea what we're talking about. So there are 9 abdominal regions: right hypochondric, epigastric region, then left hypochondric. Then we have right lumbar region, umbilical region, and left lumbar region. Then we have right iliac fossa, right iliac region, hypogastric region, and left iliac region. So there are 9 abdominal regions, and all these regions have abdominal organs. And today we're going to focus on the epigastric region. It's just below our sternum. So this is the epigastric region. I'm going to talk about the organs we have are the stomach, liver, portion of the liver, pancreas, duodenum, spleen, and the adrenal glands. So I'm going to talk about today the pancreas. So where is pancreas located? So I'm going to show you pretty quick the picture of it so you have a better idea. So pancreas is located in the, as I mentioned, in the epigastric region and located deep in the retroperitoneal space of the upper quadrant of the abdomen. And it is almost completely covered by the stomach and duodenum. You can see in this picture that it's lying behind the stomach and duodenum. And it's about 12 to 20 centimeter long in adults, and it has a lobe-like structure. So I'm going to go over pretty quick the anatomy, physiology, histology. So then we go over the pathology part. So anatomy, how many parts of the pancreas? So pancreas has divided into 5 major regions. It has a head, you can see in this diagram, head, neck, body, tail, and the uncinate process. So this is the distal end of the, and also there's the, you can see in the middle is a pancreatic duct. And then the duct crosses through the posterior aspect of the pancreatic head before passing through the head to reach the ampulla of Vater called major papilla. And there's a called duct of Ridgson, it's called mean pancreatic duct that is standing from the tail of the organ to the major duodenal papilla or ampulla of Vater. So I will just stop anatomy over here, and then I will go over the development of pancreas, the embryology. So basically, pancreas developed from the 2 buds that arise, you can see in this diagram, from the duodenal part of the foregut, an embryonic tube that is the precursor of the GI tract. GI means gastrointestinal tract. It is of the endodermal region. And pancreatic development begins with the formation of a dorsal and ventral pancreatic buds. So when they join together, and each joins with the foregut through a duct, and they form the pancreas. So I will not go further detail, just you should be aware of it from the dorsal bud and the ventral bud that make the pancreas. All right. So now next I will go over the blood supply of the pancreas. So pancreas is a rich blood supply with vessels originating as a branches of the both celiac artery and superior mesenteric artery that you can see in this diagram, the celiac trunk you can see, and then the superior mesenteric artery. So now I will move on to the histology. Histology of the pancreas, like how pancreas looks under the microscope. So pancreas has acinar cells. So these acinar cells, you can see in this diagram over here, the acini cells. So basically histology, we use eosine and hematoxylin stains that we stain the part of the cell, and we can see under the microscope. And these are acinar, pancreatic acinar cells is a functional unit of the exocrine pancreas. I will go over the physiology of the pancreas as well, but let's go pretty quick the histology part. And these acinar cells that produce the digestive enzymes. And then other part is called the islet of Langerhans cell that you can see over here, the group of cells called islets of Langerhans cells. Now I'm going to show you next over here. This again, you can see the islets of Langerhans cells. And then on the periphery, you can see the secretory acini, the acinar of the pancreas that release the digestive enzymes. So I will move on to the physiology. The pancreas has 2 types of function. So again, histology slide, you can see islets of Langerhans cells. You can see alpha cells that produce glucagon, beta cells that produce insulin, and you can see on the periphery, you can see the pancreatic acinar cells. All right, so let's move on to the physiology part. So pancreas has 2 types of function, exocrine function and endocrine functions. So as we talk about the acinar cells that are the exocrine, has the exocrine capacity. So these acinar cells, you can see in this diagram as well. So on the periphery, you can see the exocrine acinar cells that produce the digestive enzymes. So there are different types of enzymes that are produced by the acinar cells that help with the digestion. So they produce a lipase. So lipase, who can tell me what lipase, what's the function of the lipase? Can someone type in the chat box? What's the function of the lipase that is produced by the acinar cells of the pancreas? Okay, let's see. Good. Breaking down lipids, fatty acids, good. So lipase, they're produced by the exocrine cells, that is acinar cells of the pancreas. help in the metabolism of fatty acids into fats and oils. Then it produces proteases. So proteases helps in the metabolism of proteins into small peptides and amino acids. Then it produces the amylase. It helps in the metabolism of carbohydrates such as starch and sugars into simple sugars such as glucose. So these are the main exocrine function. And then pancreas has another function called endocrine function. So pancreas they have endocrine function capacity by the cells called islet cells of Langerhans. And islet cells of Langerhans are the islands of the cell you can see in the middle of endocrine cells secreted throughout the pancreas. And the number of studies have pointed to the potential of conversion of non-beta cells into producing the insulin. So what are the functions of Ehlers-Langerhans cells? The pancreatic cell that produce hormones, for example, insulin and glucagon, that are very important for our body, are secreted into the bloodstream. So there are main four cell types that each secrete different peptides. Like alpha cells secrete glucagon, beta cells secrete insulin, delta cells secrete somatostatin, and P cells, also called F cells, secrete pancreatic polypeptide. So this is the brief anatomy, physiology, histology to refresh your memory that why we have to have blood supply of the pancreas, location, so you have a better idea what we're going to talk about next. So we're going to talk about acute pancreatitis. So what is acute pancreatitis? Can someone tell me what is acute pancreatitis? Let's see. So as we talk about the pancreas, I would like to know, someone knows what is acute pancreatitis, or just tell me what is pancreatitis. There's no wrong and right answer. Just think whatever you think is pancreatitis. Inflammation of the pancreas. Good, very good. So Sarah mentioned, I really appreciate Sarah. So she mentioned inflammation of the pancreas, right? So I think I have some slides here. Okay, so acute pancreatitis is a condition where the pancreas becomes inflamed, swollen over a short period of time. And I would like to share the literature review from 2019. It shows the incidence of acute pancreatitis worldwide is increasing. And one of the most common gastrointestinal causes of hospital admission in the United States is acute pancreatitis. And this was published in 2019. And studies have elucidated mechanism of calcium-mediated acinar cell injury and death that can cause it. And recent advances in acute pancreatitis with special emphasis on pathophysiological mechanism and clinical management of the disorder. So this is a study published in 2019. And I would like to move on. The next, we have another public literature review that shows us about the pathogenesis. What pathogenesis behind this acute pancreatitis? So this literature review shows that there's a premature activation of digestive enzyme in the pancreas. So I told you before, so digestive enzymes produced by the acinar cells of the pancreas, right? So when there's a premature activation of the digestive enzyme in the pancreas has been linked to the development of pancreatitis, the inflammation of the pancreas, and for more than more than a century. And the recent development of novel models to study the role of these pathologic enzyme activation has led to advance in our understanding of the mechanism of pancreatic injury that causes cell death and injury and causes the pancreatitis, inflammation of the pancreas. So I will move on. I would like to share the causes of the pancreatitis. There are multiple causes: idiopathic, gallstones, alcohol, trauma, steroids, mumps, autoimmune, scorpion sting, hyperlipidemia, hypercalcemia can cause it, ERCP is a procedure can cause it, and drugs can cause it. But the most common cause causing pancreatitis in the Western society is alcohol. And alcohol consumption has been implicated in approximately 70% of the cases as a major cause of the disease. And developing between 30 to 40 years of age, and acute pancreatitis is more common in men than in women. And I would like to, and also second cause is the gallstones is the most common cause of the acute pancreatitis. And again, trauma can cause acute pancreatitis as well. So I will move on to clinical presentation of the pancreatitis, how patients present with the acute pancreatitis. So clinical presentation most commonly is abdominal pain. It's ranging from a sudden onset acute abdominal pain to mild episodic deep epigastric pain and possible vomiting. So I showed you the abdominal region. So where is the epigastric region? Remember, I showed you a region, epigastric region. So patient present with the epigastric pain, and acute pancreatitis may produce the constant, dull, unremitting abdominal pain, and epigastric tenderness. So when we press on this is a sign, when we press on the epigastric region, there's a reproduce of the pain called tenderness. And then patient can present with a weight loss, can present with steatorrhea and glucose intolerance. So again, diarrhea can be presenting symptom as well. So now next, I would like to share, there's a acute pancreatitis. How do we diagnose? So there are different diagnostic tools that we can diagnose pancreatitis. So there's a biochemical measurements. There is a radiological testing we can do. Like we can do a plain abdominal film, a trans-abdominal ultrasound, CT scan, MRCP, endoscopic diagnostic tool we can use. We can use ERCP and endoscopic ultrasonography. These are all the tools we can use for diagnosing pancreatitis. So I would like to share on the phases of pancreatitis. So there are two phases, the early phase and there's a late phase. So the first week, we call it the early phase. And after, when symptoms prolong after 1 week, we call it the late phase as well. And the severity of the pancreas, again, there's a mild, moderate, and severe. And in the mild pancreatitis, there's no organ failure. In the moderate one, there's an organ failure less than 48 hours. And then the severe cases, there's an organ damage longer than 48 hours. And then after pancreatitis, there's concern of the complications. The two types of complications, main two types. One is the edematous, related to the pancreas, edematous and necrotizing. So edematous, when is happens less than 4 weeks after having acute pancreatitis, and there's an acute peripancreatic collection. And when it is more than 4 weeks, is called pseudocyst. And then when the necrotizing pancreatitis, when the acute pancreatitis complication is necrotizing, in less than 4 weeks, is called acute necrotic collection. We'll talk more about it when we talk about the case studies. And then more than 4 weeks is wall of necrosis. And I will go over again pretty quick the pancreatic complications. There's the abscess formation, fat necrosis can happen, hemorrhage can happen. Then there's infective necrosis, pseudocyst formation, and sterile necrosis can happen. And the systemic complications are it can cause acute renal failure, it can cause acute liver damage, then it can be adult respiratory distress syndrome, it can cause DIC, means disseminated intravascular coagulation, it can cause encephalopathy, it can cause gastrointestinal ischemia, it can cause hypocalcemia, it can cause ileus, paralytic ileus, and it can cause shock. So I will move on to next. There's another literature review I will go over with you that was published in 2013 about the classification about these, as mentioned before, about this. A web-based consultation was undertaken in 2007. And in this study, there's a wide participation of pancreatologists who participated in this. And then they figured out the results were, I would like to share the results, that the revised classification of acute pancreatitis identified two phases of the disease, as we discussed, early and late, and the severity depends on the, again, mild, moderate, and severe, as we discussed before. So this literature review was published in 2013. So now I will move on to about the outcome. So there's another literature review published in JAMA in 2021. The outcome of acute pancreatitis are influenced by the risk stratification and also depend on the fluid and nutritional management and follow-up care, and the risk reduction strategies are very important, which were subject to review during this literature review. And there are several scoring systems, such as a bedside index. I'm going to talk about the Rensen criteria. I'm going to talk about the Apache score as well. So Rensen criteria, basically in this was published in 2022 as well. The scoring system include 11 parameters to assess the severity of the acute pancreatitis, including the age, white blood cell count, blood glucose, AST, LDH level, serum calcium level, hematocrit, and then the PO2, BUN, base deficit, and sequestration of the fluids. And now I would like to move on. There's a recent advances through randomized trials. The most common GI condition requiring acute hospitalization is requiring acute hospitalization and has a rising incidence as well. So based on this evidence, the treatment, the management of acute pancreatitis has tailored towards a multidisciplinary effort with the distinct roles of gastroenterologists. We can involve them, radiologists, and surgeons as well. So this study literature emphasizing the evidence obtained by the randomized controlled trial. So this literature review showed us that we need to have a multidisciplinary effort to manage the acute pancreatitis. All right. So next I will move on. So predicting the severity of acute pancreatitis has diverse etiology and natural history. So some patients have severe complications with high risk of mortality. So prediction of severity is very important. Careful ongoing clinical assessment is very important, and multiple factor scoring system and imaging studies have been published in another literature review, in this literature review that was published in 2022. But mentioned that there is no ideal scoring system with high sensitivity and specificity. So now I will move on after talking about the literature review, the basic anatomy, physiology, about their pathophysiology, their pancreatic function. I'm going to move over the clinical cases. And now I would like your participation here, and you have to tell me what's going on. And let's start with our first case about, let's see over here, where is my first case going on? Yes. So I will move on to the first case. So this patient is a 63-year-old female evaluated in the emergency department for an 8-year history of abdominal pain in the epigastric region that radiates to the back. The patient is nauseated, patient is anorexic, patient is tachypnic, and in moderate distress. She has no other medical problems and takes no medications. So this is a physical examination. On examination, patient is febrile, temp of 102.4 Fahrenheit. Breath sounds are decreased at the lung basis. Vitals, blood pressure is 160/98, pulse 102 per minute, and respiration rate is 26 per minute. BMI is 33. And exam, I missed some part. This patient on examination, abdomen was distended. There was a tenderness with palpation in the epigastric region, but there was no masses or peritoneal signs were noted. So lab studies showed hemoglobin of 15 gram per deciliter, leukocyte count was 16,300. Amylase level was 35,312, BUN was 64, creatinine was 2.4 milligram per deciliter, lipase 12,642. So imaging results showed, we obtained the CT scan that shows that demonstrate pancreatic and peripancreatic edema without evidence of necrosis. So there is no evidence of mass lesions in the liver or pancreatic fluid collection. So now, this is again the snapshot of all the case I just discussed with you. So I need to ask you guys, which of the following most accurately predicts a severe clinical outcome for this patient? What do you think among all these options? A, amylase and lipase levels. B, blood urea nitrogen. C, peripancreatic edema on CT scan. D, temperature. So what do you guys think is the correct answer? What is the severe clinical outcome for this patient? Let's see how many responses we receive. Again, just give, if you don't know the answer, it's okay. Just do the best educational guess that we talk about. And this is the learning phase. And we'll discuss in detail why one option is right, why options are incorrect. Why, of course, I talk about that we do all these tests, right? So why we do these tests? So let's see, we got a response that A, BUN, okay. Right, so serial BUN measurements may be the most reliable routine lab test to predict the severity of acute pancreatitis. So I would like to share the educational objective in this, why we are choosing BUN, why we are not choosing the other. So as we know, patient had elevated BUN, patient had a fever as well, patient CT scan showed some finding. So all those were there. So why we're choosing B option, BUN? So the reason behind this, the educational objective to learn here is the blood urine nitrogen level is the most accurately reflects the prognosis. So over here, we are trying to figure out the prognosis of this patient. So this patient has acute pancreatitis, as we can see from the history, we can see from the examination. So patient has developed evidence of systemic inflammatory response syndrome. Why? Because patient had a fever more than 100.4 Fahrenheit. Patient has a leukocyte count more than 12,000, like in this patient has 16,000, and patient has a respiration rate more than 20 per minute. Patient was tachypnic, right? As we discussed in the history in this case scenario. So in this observational study of the patients admitted of 69 different hospitals with acute pancreatitis. And the serial BUN measurements were the most reliable routine lab test to predict the mortality of that patient. For every 5 milligram increase in BUN during the first 24 hours, the age and gender adjusted odds ratio for mortality increased by 2.2. And it was about 95% confidence interval limits. These are all the statistics I'm sharing with you. And the change in hemoglobin concentration did not correlate with the severity. So there's the reason. And again, why not other options? So amylase and lipase level do not provide any value in terms of predicting the severity of the acute pancreatitis. They can help us, they're a diagnostic tool, but these tests should only be used to make the diagnosis of the acute pancreatitis, but not the prognosis. So in addition, they should not be used to follow the patient progress while in the hospital because their levels generally do not correlate with clinical improvement or decline. And why, of course, then most episodes of acute pancreatitis are of mild interstitial form. So almost all the associated morbidity and mortality occur in patients with necrotizing pancreatitis are particularly infected pancreatic necrosis, so which has a mortality rate of about 10 to 30%. And then we can see in the CT scan, the peripancreatic edema on CT imaging is not a marker for severity in acute pancreatitis. That's the reason we will not choose the CT scan option. And then the high fever, the patient has elevated temperature, is not considered an independent marker of severity in acute pancreatitis. So that's the reason this observational study that shows the BUN give us the better prognostic value. So this is the B is the right answer. And as we talk about the educational objective, the takeaway home point is serial BUN measurements may be the most reliable routine lab test to predict the severity of the acute pancreatitis. All right, so let's move on to our next case. So this scenario, this case number 2. So this patient, 48-year-old male, is evaluated in emergency department for a 12-hour history of severe epigastric abdominal pain. He has a long history, standing history of alcohol use. So as we talk about, alcohol is the most common cause. And the pain developed gradually, radiates to his back, and is associated with nausea and diaphoresis. So physical examination, patient is afebrile, patient oropharynx is dry, there's absent breath sounds and dullness to percussion noted in the left lower lung field, and abdominal examination discloses epigastric tenderness to palpation. So what it shows us, it shows us acute pancreatitis, right? No splenomegaly, cutaneous signs of cirrhosis or peritoneal signs, vital signs, blood pressure is within normal range, pulse 95, respiration rate 18, BMI is 35. So lab studies shows hematocrit 54%, leukocyte count is 14,100, alkaline phosphatase is 105 units per liter, total bilirubin is 0.8 milligram per deciliter, BUN is 68, creatinine is 1.9, alanine aminotransfer is 24 units per liter, AST is 29 units per liter, amylase 2,342, bicarbonate is normal, LDH is normal, lipase is 1,232 units per liter. So what do you think what's going on? So what do you think, what's the diagnosis based on all these history, physical examination, lab findings? So we know that patient has acute pancreatitis based on history, examination, and lab findings, right? A diagnostic tool is there. So before, and I will go over the imaging results as well, the CT scan demonstrates peripancreatic edema and hypoperfusion of the pancreatic body. So this will give you a clue what's going on. What's the diagnosis first? Then we'll go on, move on to the next step. And a left pleural effusion is noted. There are no fluid collections or free air. So before answering this is a snapshot of this case study. So which of the following is the most appropriate initial treatment? So there are 4 options. But before going to jump on the best initial treatment, I would like to know what is the diagnosis. We know that patient acute pancreatitis, and we talk about the complications, right? We talk about the pancreatic complications, and we talk about the systemic complications. So what do you think is going on? So in this scenario, let's see if someone can participate. Let's see if we get some responses. Okay, I know it's tough for you guys. So this patient has acute pancreatitis, and the complication, okay, we got one response. Okay, they jump onto the NG tube. Okay, so before I'm asking, my question was, we know that patient has acute pancreatitis. I'm asking, what do you think is the diagnosis? So in this scenario, patient has acute necrotizing pancreatitis. That is a complication of acute pancreatitis. Okay, so this based on the clinical symptoms, patient has elevated amylase lipase. CT scan is very important, demonstrating the hypoperfusion of the pancreas, and necrosis can be defined by CT scan only when there is a hypoperfusion of the pancreas. So in the CT scan, we talk about, again, go back over here, the CT scan imaging is showing the hypoperfusion. So that shows us patient has acute necrotizing pancreatitis. And now when we have the diagnosis, now we are going to move on. What is the appropriate initial treatment? Let's see who can answer. We just got one response. Someone said D, NG tube. Okay. What else? Anyone can participate? Anyone would like to share? What do you guys think? If you don't know, it's okay. Just give your educational guess. Okay, let's see. Yeah, we got a few responses over here. Let's see. So yeah, Sarah said C. She said B, ERCP. Okay, all right. Yeah. So in this scenario, the first initial step is aggressive hydration with IV fluids. Why? So again, in the education objective in this, aggressive fluid resuscitation is one of the key initial measures to avoid organ failure in acute pancreatitis. So there's a reason we have to start. The first best step will be the hydration, aggressive hydration with IV fluids. It can be normal saline. So we can start hydration right away to prevent the organ damage, as we talked about before, right? So why not B? So broad spectrum antibiotics. So they are generally not used in acute pancreatitis. Why? Even if it's necrosis, we don't use it. And I will show you some literature study as well. Even if necrosis, we don't use it because there's several randomized controlled trials have demonstrated there's no benefit of IV antibiotics as prophylaxis against infection in severe necrotic pancreatitis. In addition, the use of antibiotics without documented infection may contribute to the development of intra-abdominal fungal infection. So we have to keep in mind. So we don't have to jump on right away. We can start some point later on, but initial treatment. So you have to look at they're asking appropriate initial treatment, the first step in management we're asking, right? So in addition, the use of antibiotics can cause fungal infection, and also patient with pancreatic necrosis, there's a concern for infection should undergo if there's concern for infection, so patient should undergo percutaneous fine needle aspiration for culture and gram stain for the infected pancreatic necrosis. Then when it's positive, then we can start the antibiotic. So patient should receive antibiotic only if infection of the pancreas is documented by tissue sampling. That's the reason it's not the first option. And then ERCP. So ERCP may cause a flare in pancreatitis. So it is performed rarely in acute pancreatitis, and ERCP should be performed only if a patient with gallstone pancreatitis. So remember, we talked about two more most common causes. First was alcohol, second was the gallstones. So when there's suspicion for gallstone pancreatitis, then we move on to ERCP, and it has a worsening, when patient has a worsening liver chemistry, then we can move on to this step, but not the initial step in this scenario, in this case study. And also someone mentioned about NG tube. So why not NG tube? So NG tube decompression is not advocated in the management of acute pancreatitis because it does not lead to improve the outcome and will interfere with the early enteral feeding. So we should avoid NG tube as an initial step. All right, so I will move on to case number 3. So this was, again, I will pretty quick, I will go over the education objective for our case study number 2. So aggressive fluid resuscitation is one of the key initial measures to avoid organ failure in acute pancreatitis. All right, so let's move on to our third case. Let's see, someone can read it for me from the students. I would like someone to participate and read it for me, read it for all of us. Let's see who can raise hand, and you can unmute yourself and read it for us. Okay, no one want to volunteer? Okay, that's fine. Okay, so case number 3. So this is a 72-year-old gentleman evaluated for a 2-week history of painless jaundice. So just, patient's history is very important. They give us a diagnosis. Then based on that, we can do a management plan. So the patient also has pleuritis, anorexia, and weight loss of 4.5 kg, about 10 pounds during the same time period. He takes no medications. So on examination, physical exam, patient is afebrile, no lymph no hepatosplenomegaly, no cutaneous signs of cirrhosis. Patient appears thin. Patient has a scleroicterus and jaundice are present, and there's a gallbladder is palpable. And vital signs, they're not with a normal range. BMI is 22. The lab studies shows alkaline phosphatase of 522. ALT is 354 units per liter. AST is 215 units per liter. And the complete blood count is normal. Total bilirubin is 12.1, and direct bilirubin is 10.7 milligram per deciliter. So imaging studies, CT scan, the contrast enhanced CT scan showed dilated common bile duct with focal cutoff in the pancreatic head, but there's no focal mass noted in the head. The pancreas duct is dilated, and there's no evidence of mass lesions in the liver. So first of all, I would like to know, what do you think what's going on? What's the diagnosis? Given history, patient has a weight loss, patient has a jaundice, patient has elevated liver function. So what do you think is going on with the patient? Can anyone give me the diagnosis? Yes, someone answered. Okay, good. Very good. Let's see. He may have gallstones. Okay, good. Yes, it's a possibility. So I really appreciate, Sarah, your participating. Participation matters. I always tell all my students, my kids, participation matters. It doesn't matter you're right or wrong. This shows that you're participating, you're paying attention, you're giving your best. So yes, so diagnosis in this scenario is a pancreatic cancer. So so now my question is, which of the following is the most appropriate initial management? Like we're thinking on those lines. So we have to, these are all the tests. A, obtain serum CA19-9 concentration. B, perform abdominal MRI. C, perform endoscopic ultrasonography of the pancreas. D, refer for pancreatiduodenectomy. So we know from the scenario, from the case study, that patient has pancreatic cancer. We're thinking on those based on just history. Now we have to do next best step was the initial treatment. So what do you think? What you will choose? Let's see if we get any responses. Again, participate, see what do you think is right. So initial treatment, she said C, Sarah said B. Okay, good. I really appreciate your participation. So answer is C. Good. So this patient, why is C? So education objective in this one, we'll go back. And so why C? The initial treatment, perform endoscopic ultrasonography of the pancreas. The reason is the patient most likely has pancreatic adenocarcinoma. We'll talk about briefly about the pancreatic cancer as well. The pancreatic adenocarcinoma is the most common cancer. So based on the CT scan findings, so in elderly patients with painless jaundice and a focal cutoff sign of the bile and pancreatic ducts with upstream dilation, that as mentioned, the CT scan findings, a diagnosis goes towards the pancreatic malignancy is the most likely differential diagnosis. And how we will confirm it. So EUS is as accurate as CT scan for detecting tumors and maybe more sensitive for tumors smaller than 2 centimeters in diameter. So why EUS? So EUS with fine needle aspiration biopsy can provide the specimens for histological evaluation. MRI and CT scan are not as sensitive as EUS for detecting tumors less than 2 centimeters in diameter within the pancreas. So we have to be careful. Over here, we mentioned the size. So less than 2 centimeters, only EUS is more sensitive than MRI and CT scan. And the serum concentration of CA19-9 increases with pancreatic cancer. So particularly in unresectable tumors, but this test has a low sensitivity and specificity, and that's why it cannot be used as a screening and test or not as a diagnostic tool for the pancreatic cancer. So EUS is as accurate as CT scan for detecting pancreatic tumors and may be more sensitive for tumors smaller than 2 centimeters in diameter. That's the reason we will choose the initial management as the EUS. And MRI is unlikely to be any more successful in detecting the pancreatic tumor than the CT scan. So if EUS is not in the option, then we can choose the CT scan. So, and pancreatic duodenectomy should not be performed because we don't have a definite diagnosis, has not yet been established at this point. All right, so I will go over pretty quick the pancreatic tumors. And from this, again, takeaway point from this learning objective is EUS is as accurate as CT scan for detecting pancreatic tumors and may be more sensitive for tumors smaller than 2 centimeters in diameter. So I will go over briefly the pancreatic tumors. So pancreatic tumors, again, based on the function of the pancreas. So the reason I brought up the function, pancreas function, endocrine function, exocrine function. That's how we differentiate tumor as well, exocrine tumors, endocrine tumors. So exocrine tumors, the most common type of pancreatic cancer is the exocrine tumors, and more than 90% of the cases have the exocrine pancreatic tumors called adenocarcinomas. So as we talk about exocrine functions, what's of exocrine? I learned digestive enzymes, lipase, amylase, right? Protease. So these are all the enzymes released from the acinar cells that we talk about. We saw this histology diagrams of the pancreas as well. So these are the adenocarcinomas of the pancreas. More than 90% of the pancreas are the exocrine adenocarcinomas. So other types of pancreas that are less common are the endocrine tumors, or called the pancreatic neuroendocrine tumors. So as we discuss the endocrine function of the pancreas as well, right? We talk about the alpha cell release glucagon, we talk about the beta cell release insulin. So, and I would like to share a fact that Steve Jobs that helped us having our iPhone, that we can get all kind of information. So Steve Jobs was diagnosed with a rare form of the pancreatic cancer called the islet cell tumor, or it's called neuroendocrine tumor. So that is a rare tumor, and that arises from the islet cell of Langerhans, and which is a different form of pancreatic tumor, and it's very aggressive, it's highly aggressive tumor, and often rapidly fatal as well. And it's less common than the exocrine pancreatic tumors. And so these, as we know, the gastrin release is called gastrinoma, a tumor that forms in the cell, so it's called gastrinoma. So when a cell produces too much insulin, is called insulinoma, that tumor that forms in cells that makes more insulin. Then glucagonoma, a tumor that forms in cells that makes more glucagon. So there are basically 5 main types of functioning pancreatic neuroendocrine tumors called insulinoma, gastrinoma, smatostrenoma, glucagonoma, and vipoma. So I will not go in more detail. I will just give you an overview of the pancreatic neuroendocrine tumors. And I will go over pretty quick. The literature review published in 2012, and the frequency of the incidental detection of pancreatic neuroendocrine tumors and analysis of incidence and outcome. So I'm very humble to share that I'm the author in this literature review as well. And this literature review mentioned the frequency of the incidental detection of neuroendocrine tumors is increasing. And again, there are stages. Most stage 1 tumors found in the study was 55% were incidental tumors. And on multivariate analysis, the incidental detection of tumors was the strongest prognostic factor for progression. And this study highlights the necessity of developing the guidelines for management of patients with incidentally discovered the early stage tumors. All right, I will stop here and I will move on to the case number 4. So in this case, this is a 42-year-old female is evaluated following hospitalization for acute pancreatitis due to gallstones disease that occurred 8 weeks ago. And CT scan or admission demonstrated no evidence of fluid collection or necrosis, and she had an uncomplicated cholecystectomy prior to discharge. She has no pain, no nausea, no anorexia. However, 2 weeks ago, she was evaluated for nephrolithiasis following an episode of renal colic and underwent a CT scan. So patient has a flank pain, patient underwent a CT scan, and they found stones in the kidneys. So imaging results, I will go over the imaging results. So CT scan demonstrated a 4 millimeter stone in the right ureter. So, and 6 millimeter fluid collection adjacent to the pancreatic tail. So remember, we talked about the part of pancreas: head, neck, body, tail, and encinate process. So in the tail portion, they found a 6 centimeter fluid collection, and there was no evidence of solid debris, and it did not communicate with the main pancreatic duct. There was no mass lesions in the liver, and there was no pancreatic necrosis. So she has since passed the kidney stone, and patient was asymptomatic. These are all the CT scans. So physical examination, on the physical exam, abdomen examination disclosed a non-distended abdomen, and there was active bowel sounds. There was no tenderness on palpation. There was no hepatosplenomegaly, and there was no other masses were noted. And vitals, Temp was 99 degrees Fahrenheit. Blood pressure was normal, 112/72. Pulse within normal range, 66 per minute. Respiration, 18 per minute. BMI was 25. Lab studies obtained, complete blood count was normal, liver chemistry were normal, CA99-9 was normal, alkaline phosphatase were normal. So what's going on? So again, which of the following is the most next step in management? So first of all, we need to know what's going on. What's the diagnosis? Again, we have all the history, we have all the CT scan findings, we have all the labs we have with us. So what's going on, first of all? So we know that from this history and physical examination, this is, I can give you a clue, there was one of the acute pancreatitis complication. So we talk about one complication, acute pancreatitis, necrotizing pancreatitis. Now this is another complication that can occur. So this is the pseudocyst. So diagnosis is the pancreatic pseudocyst. And I need to know which of the following is the most next step in management. So we know that patient diagnosis, I'm giving you the diagnosis, patient has pancreatic pseudocyst and asymptomatic pancreatic pseudocyst. So what do you think? What is the next best step in the management of this patient? A, endoscopic ultrasonography. B, magnetic resonance cholangiopancreatography. C, percutaneous drainage. D, surgical drainage. E, no further diagnostic testing or therapy. So what do you think what's going on? So we talk about the diagnosis, pancreatic pseudocyst. So what do you think is the initial step in management for the pancreatic pseudocyst? I would like participation. Sarah said C. Sarah said E. She's mentioned C. And if the patient is symptomatic and already passed, okay, E. Okay, good. So C and E. Okay, good. So let's go over all the options one by one. So you're right, there's a E. Answer option is the E. No further testing, diagnostic testing or therapy needed. Why? So the education objective here is to manage the asymptomatic pancreatic pseudocyst, because we can see on the CT scan finding, we figured out there's a cyst sitting there next to the tail of pancreas, right? So the patient required no further diagnostic testing or therapy. Why? Because patient has an asymptomatic pancreatic pseudocyst that developed as a result of her acute pancreatitis 8 weeks earlier. So pancreatic pseudocyst, as we mentioned, is one of the complications of the acute pancreatitis. Is basically the cyst of pancreatic juice that have a fibrous non-epithelial lining that occurs around the gland. And they are the most common complication of the acute pancreatitis. The cysts generally take at least 4 weeks to develop. And the cysts generally often resolve spontaneously. And they are usually asymptomatic. So then when sometimes it can cause pain or obstruction as well by pressing against other organs, because this patient did not have a fluid collection at the time of initial presentation, right? And we talk about the initial CT scan on the presentation, and the collection is a result of the pancreatitis and not a cause, right? So she requires no further testing and or any therapy because she is currently asymptomatic. So the education objective is for asymptomatic pancreatic pseudocyst, no further diagnostic testing or therapy is needed. But because why? Because it typically resolves itself. It typically resolves spontaneously, so it does not require any treatment. So why not EUS? So EUS is used to evaluate the cystic lesions of the pancreas. So there's several criteria can be used to identify a mucinous cystic lesion that requires removal, including the presence of septation. You can have echogenic mucin in it or have a mass in it. But in this patient, EUS is not necessary because there is no concern about a mucinous cystic lesion. And why not MRCP? So MRCP is a non-invasive technique for imaging the bile ducts and pancreatic ducts. So in a patient with pancreatic pseudocyst, MRCP might not be useful to determine if the cyst is connected to the biliary or not. However, MRCP is since it's not necessary because CT scan does not document a connection between the lesion and the main pancreatic duct. Remember I mentioned about in the pancreatic tail. So it didn't mention any connection. So why not percutaneous drainage or surgical drainage? So they are not indicated at this time because the patient is asymptomatic. If patient is symptomatic, then of course drainage would be advised only if the patient develops symptoms. What are symptoms? Like patient has a pain, patient has a febrile illness, or patient has anorexia. So when patient is symptomatic, then of course we have to go towards a drainage. All right, so I will go over pretty quick the literature review. So again, takeaway point, asymptomatic pancreatic pseudocyst following acute pancreatitis typically resolve spontaneously and do not require treatment. So these, all the case studies will help the students in your USMLE steps, in your board exams, in your clinical management as well. So these are for all broad spectrum. So I started with the basics. So it can help with the students as well, for undergrad students to understand the anatomy, physiology, and then I went over the board review, USMLE level questions as well. So everyone can benefit from this session. All right, so I will go over the pretty quick literature review. So I will say the management of severe acute pancreatitis. So severe acute pancreatitis, based on this literature review published in 2021, continues to be a serious gastrointestinal disease with relevant morbidity and mortality. So what are the management plans? So this literature review shows us successful clinical management requires close interdisciplinary team cooperation and coordination, and key takeaway message is early targeted fluid therapy within first 48 hours is critical to improve the outcome of severe acute pancreatitis. As we share one case study as well, and I asked you the question, what is the initial best treatment, right? Initial management. So initial fluid targeted therapy should start it as soon as possible to help to improve the outcome of the severe acute pancreatitis. All right, so now I will conclude over here my clinical cases. I hope you guys will benefit from these cases in your board exams, or your USML exams, in your literature review, and your for students as well to have a better idea about this abdominal organ sitting as a retroperitoneal organ. All right, so as most of you know from my prior sessions, that I talk about the self-care as well. So I will go over briefly, very quick, what is self-care? I would like your feedback, your thought process. What do you think is a self-care? Can someone would like to share in the chat box? If you want to talk, you can raise hand, you can unmute yourself, and you can share. What is self-care? What do you think? What is self-care? What is self-care for you? Let's see if we get any responses here. Anyone would like to share what is self-care? Okay, anything that helps us manage our physical, mental, emotional health? Good, very good. Sarah mentioned this, and then to be mindful of yourself and well-being management. Okay, good. All right. So self-care, again, I will say why we need a self-care, but first, self-care is a process of establishing behaviors. It's being said we are creatures of our behaviors. So it's basically the process of establishing behaviors to ensure well-being of oneself, to promote health and maintain the health, right? So basically it's the individual's engagement in some form of self-care on daily basis with your food choices, with your daily activities, with your sleep hygiene, your intellectual health. Like this time, this session, this hour, this time, we're learning, right? We're helping our intellectual health. We're working on intellectual growth. We're helping on intellectual intelligence to learn something new, to help us, right? So basically it's a practice to taking action to preserve and improve our own health. So now I will ask next, why do we need self-care? As a clinician, as a medical student, as a pre-med student, as an MD, as a human being, why do we need self-care? I would like to, your interaction, I would like your participation as well. What do you think? Again, there's no wrong and right answer. Why do we need self-care? Okay, let's see. We receive a response here. Because of the journey of medicine is long and challenging at times. Yes, definitely, yes. So medicine is a very rewarding profession. And we always say it's a marathon. It's not okay, yes. Let's see, we have another response. To maintain our health, especially in stressful times. Yes, definitely, yes. We need self-care. So we need self-care because we cannot give it to others what we don't have. We give it to others what we have. Like if I have money, I will give it to others. I will do charity. I will help others as possible, right? If I have food, I will give it to others. If I have some skills, I will share with others. If I'm healthy, then I will. If I am sick, at this hour, I will not be sitting with you, talking with you, have interaction, this interactive session with you guys, sharing some knowledge with you or some refreshing knowledge with you, right? So basically, but we give it to others what we have. So you have to have Pay special attention to your self-care as well, so you can help yourself and help others. That's the reason we have to pay attention to our self-care as well. And I will go over pretty quick. The self-care has 4 domains, as I discussed in my previous session as well. So self-care has 4 domains. We have to pay attention to all 4 on daily basis, just for 5 minutes, 10 minutes. It's very important. Be mindful about self-care. Physical health, physical intelligence is about our body. Then intellectual health, our vision, our mind, right? This is, at this time, we are trying to learn something new, right? Something refreshing our knowledge. Then emotional health, emotional intelligence. It's about our passions, it's about our emotions. We have to take care of our emotions and pay attention to our other emotions as well. And then spiritual health, spiritual intelligence is basically our spirit, right? So we have to pay attention all 4 areas. Why all these 4 areas? Like table has 4 legs. I give the example. If one leg is wobbly or one leg is broken, the table will be wobbly, right? So that's the reason we have to pay all these 4 areas to take care of ourselves as well. So I will go over briefly all these 4 areas one by one. Physical health. Why we need physical health? Physical activity, right? So I made acronym for myself as well to keep myself as I call it self. As for sleep hygiene, pay attention, make sure you have enough sleeping hours, then exercise regularly, even for 5 minutes, brisk walk, go stairs up and down, better standing instead of sitting. So any movement is better than no movement. And learn to manage stress, as Benny mentioned, that we have to take ourselves because of self-management. So learn how to manage stress, have some coping mechanism to manage stress on daily basis, okay? And most importantly, food, have a nutritious food, add more fruits, vegetables in your diet, add more green leafy vegetables in your diet, avoid any junk food, okay? So all these 4 areas is about the PQ, physical health, physical intelligence. Now I will move on. Emotional health, emotional intelligence. It has 4 skills as well. It's about self-awareness. What is self-awareness? Can someone tell me what is self-awareness? Can someone type in the what do you think about self-awareness? I would like your participation. I would like to learn from you guys as well. So what is self-awareness? So I will, by the time you think about and type in, I would like to share the emotional intelligence concept was first time introduced by the Daniel Goleman in 1995, and I would like to share her book as well. And he wrote a book on it, Emotional Intelligence. And yes, so Sarah mentioned understanding your own mental state and emotions. Good. Understanding ourselves and those around us. Very good. Yes. So basically, emotional intelligence plays a vital role in our growth, in our health, in our success. We all want to achieve our goals, right? We all want to be successful. We all want to help ourselves and help others as well. So there are basically 27 emotions. I will not go in the details, but there are 7 universal emotions: happiness, sadness, anger, fear, disgust, surprise, and contempt. So emotional basically is how we think, how we feel for ourselves and for others, right? And basically it's about a sense of well-being, our ability to cope with the life events, ups and down time, happiness, how we react in the anger time, how we react when we are sad, how we react, how we manage our stress. So how we acknowledge our own emotions as well as other emotions as well. So it doesn't mean being happy all the time. It means to know your emotions and then understand other people as well. So self-awareness means, I would put a very easy way, know your own strengths and weaknesses, and improve your strengths and polish your weakness area. And also you can work on weaknesses and you can polish your areas that need more, that you feel like you're deficient, and you can improve those as well. So it is being said that IQ is one of the, as for board exam, for USMLE exam, for pre-med school, for MCAT exam, we all need to put a lot of effort, right? So everyone say we need high IQ, but IQ is one of the most important element of intelligence. However, we need to have EQ as well, emotional health, emotional intelligence as well, to achieve our goals in our life. So again, emotional intelligence have 4 domains: self-awareness, know your deficiencies, your weaknesses; self-management is again self-discipline. To be successful, self-discipline to success. I would share that anyone who want to be successful means want to achieve your goals, want to anything you have aim, you have your goals, you have to be self-disciplined. Your time management, your self-management, your time management, your all your skills that need to polish. And then social awareness. What is social awareness? Social awareness means to know other people as well. Put yourself in other people's shoes as well. Like at workplace, someone is very upset, someone is angry. So when they're angry, the emotions are very contagious. When someone is angry, we get angry as well. We get upset as well. So that is a time of the highly emotionally intelligent people understand the emotions that are driving other people and themselves. So they learn how to be calm and quiet in those circumstances, those events, to manage those conflicts, to manage those anger events. So social awareness to understand other people as well. And then relationship management. It can be relationship with, I will say, of course, your sibling relationship, your parents, kids relationship, and most importantly, in this scenario, I would like to talk about the doctor-patient relationship. Sometimes you will find a very difficult patient. Sometimes you find a very emotional patient. How you will manage those patients, right? So when you have a high EQ level, your emotional intelligence is high, then you will understand other people as well. And most importantly, it will help you, your doctor-patient relationship, to polish your skills in those areas as well. All right. So next, this is Daniel Goleman book. I would like to share. If you want to learn more about emotional intelligence, you can learn. And then next move on, I will go to intellectual health, IQ. So it's also very important element, and it has 4 areas that we need to work on: our verbal intelligence, our working memory, our processing speed, our logical reasoning. So these are all the IQ, how we can improve. Read different articles, read different books, learn from your mentors, add mentors in your life. Spend time in reading books. Books are best, make books your best friends. Even some time of the day, 15 minutes, 10 minutes, learn something new every day. All right, so last but not least, spiritual health. It again has 4 quadrants: our moral values, our ethics, what is important to us, our principles that we set for us, right? Honesty, integrity, responsibility, and then most importantly, life purpose. What is the purpose of life? Why we're in this world? Why we all woke up this morning, right? We need to define a purpose of life. God has given us another day. And the social responsibility. So we need to understand, when we feel like we have achieved our goals, then this is the time to pay back to the community. So at some point, like one candle lit another candle. I always give the example. So always think in mind. Always working on these areas, achieving your goals. While working on your goals, you can start working community services as well. Help as much as you can, even an hour over the weekend, even half an hour over the weekend. Go for the churches, mosques, your areas, your community areas. Serve as much as you can, even half an hour once a month. So try to, in a social responsibility, help as much as you can, help other people, serve the community, serve the humanity. And last but not least, attitude of gratitude. Always be thankful for your blessings. Sometimes we feel we are working so hard. Of course, for any successful people, we see the tip of the iceberg. We don't see the sacrifices. We don't see the failure. We don't see a lot of depression, stress, right? We just see the tip of the iceberg. So always be thankful. One day at a time. Take small baby steps, and one day, and you will learn that small baby steps make a giant steps, and you will achieve your goals, and you will be in the position to help others, help humanity, serve humanity. All right, so I will stop here, and pretty quick, this is again physical health, emotional health, mental health, and spiritual health. And what is success? Briefly, I'm going to go over. Everyone has their own definition of success, right? So I would like to ask you guys, what do you think? Then I will share my definition, what I think success is. One word, one sentence, whatever you think. What is success means to you? Anyone would like to share? Any one word? As I mentioned, everyone has their own definition, own way of defining their success. So there's no wrong and right answer. So just in one word, what do you think is success for you? Living a life that makes you happy and gives you a feeling of fulfillment. Yes, good, very good. Sarah mentioned this. Then she mentioned growth and being better than we were in the past. Good, very good. Yes. So success, definitely, everyone has their own definition of success. So some people say monetary value. Some people say achieving our goals. Some people say serving the humanity, right? So everyone has their own way of defining the success, where you feel fulfilled. So definitely everyone has their own definition of success, and keys to success I would like to share: be proactive, whatever you want to achieve in your life. Prioritize your goals, prioritize your options, and most importantly, perseverance. Even small baby steps every day, 5 minutes, even 1 minute, do each and every day. And most importantly, practice, practice, practice. There is no magic in this world. Everything is practice. So whatever you practice, like if you know already the subject, go and revise again, refresh your memory, and then passion. So I always say your passion and profession should be the same. If your passion and profession should be the same, you're not working a single day because you love it. Why? When we are passionate about something, we are out of time and space. We don't care if we're getting paid for that. We don't care if we are getting acknowledged for that or not. We're so passionate about it. We're out of time and space. So whatever you do, be passionate about it. Ask yourself, be truthful with yourself, and never give up. And have a grit. So always, I will stop here and just I will wish you best wishes for all of you. Good luck with your careers. And if you guys have any questions, you're more than welcome. And thank you everyone for spending this weekend morning to learn something. And of course, share your thoughts with me as well. And always try to learn something new, even if it's from 5 years old. I would love to learn anything new. Okay. All right. So I'll stop here. And if you have any questions, please feel free to, you can chat in or you can raise your hand. And you are welcome to ask at this time. Thank you, everyone.
All right, thank you, Dr. Cheema. We're now going to conduct our closing session with our quiz and future session dates. The link to the quiz for the session is now live. Again, you'll need a 70% or higher to pass and receive certification, and that link is being sent in the chat now. Now on to our next session dates. I'm looking forward to seeing you all our next session next Saturday, March 25th at 10 a.m. Eastern Standard Time with a physician mentoring us in dermatology. Thank you everyone for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing.
question